I will hand over the session to Chris McIntyre. I believe he doesn't really need an introduction. He is one of the nephrologists who really transformed the field through his research, and we are very pleased to have him here for a keynote address and to chair the first session.
Thanks very much.
So without further delay, I'd like to welcome the first speaker, Judy Weintraub. Judy has a long background in education and in psychological science, and almost as long a background in experiencing chronic kidney disease, having suffered from chronic disease for 38 years and being dialyzed on hemodialysis for most of that, for the last 11 years on nocturnal hemodialysis. I think it's particularly important and pertinent that we start off this conference with somebody who has an intimate engagement with the patient perspective, as the patient is at the centre of everything we do, and the principle of no decision about me without me is critically important. I'm very pleased that the topic is about the spectrum of CKD, stressing that our patients are not hemo patients or PD patients or transplant patients, but it is a journey that they go through over an entire lifetime. Many thanks.
Good morning, everyone. First, I want to just say, yes, I have been on dialysis for that long, but not always suffering with it. I want to also mention before I begin that in thinking about how many years I've been on dialysis and looking around the room, I have been actually doing kidney dialysis longer than some of you have been on this planet. I want to thank Renal Research Institute for inviting me here today to speak with you, and particularly to Peter Kotanko, who was kind enough to invite me, and I'm thrilled and honored and privileged to be here. Okay, next slide, please. I'm going to begin by telling you a little bit about what I've done with my last 38 and a half years on dialysis. I celebrate that time, and this is why. During the time I've been on dialysis, I began dialysis at age 15 in 1975. Those of you who are quick with numbers can very quickly figure out how old I am. And so my first goal was simply to graduate from high school. From there, my next goal was, please just let me get to college. I graduated from UCLA with a degree in psychology. From there, I went on to University of Southern California, and I graduated with a degree in special education and a few different credentials to teach hearing impaired children and communication handicapped children. From there, I became an early intervention specialist, working with parents of children with hearing loss and working with children themselves from birth to 5, developing language, speech, and auditory skills. After that, I was a professor at USC, working in the graduate program in special ed, training teachers to work with children who are hearing impaired. That went on until about 2001. In the mid-90s, something was pulling at me inside, and I realized I needed to turn my attention to healthcare advocacy, to help educate patients and their families, give them hope, empower them, and encourage them. So I started a chapter of a nonprofit organization called the American Association of Kidney Patients in the mid-90s. I founded that chapter, was president of that chapter. We gave monthly seminars, quarterly newsletter for more than a decade, and we helped thousands of patients during that time period. That was more than a decade. Next slide, please. How did I do this during this whole time? I began with in-center dialysis in 1975. If I began just 5 years earlier, I probably would not have been selected to initiate dialysis, because that was the years before the ESRD Act, Medicare was passed in 1973. I began treatment in 75. and I did in-center hemo for 12 and a half years. During that time, I had my first kidney transplant when it was really hit or miss, and was definitely miss in my case. I had that transplant for only 3 months, and it was a really, really life-threatening time. It was very, very difficult period. I made it through that period and went on to dialyze in center, received my second transplant in the mid-80s. That transplant went into shock, and then my body rejected it. That transplant never opened up. I was never off dialysis for the second transplant. After that transplant, I had a long talk with my fantastic nephrologist, Dr. Frank Strauss, who is here today. Raise your hand, Frank. Thank you. Frank is now retired, but he has become he is such an advocate for me, such a dear, dear friend. Thank you, Frank and Merle, and Daniel, my nephew, for being here today. Okay, so I switched to peritoneal dialysis. When I began hemo in the mid-70s, how many of you know of what dialysis was like in the mid-70s? Show of hands, please. Okay, peritoneal dialysis was considered a last resort in the 70s, but by the time the mid-80s rolled around, CAPD was something that was viable, safe, and actually provided many, many health benefits beyond what hemo could provide. I am today, I continue to be a huge advocate for PD, so please educate yourselves about what a fantastic modality hemo PD is. I went on, I switched to CAPD. I was on CAPD for 12 and a half years. It was the strongest 12 years of my life. I worked full time. I took classes in writing. I danced like a maniac on the weekends. I skied. It was the strongest period of my life. 12 and a half years, not one infection, same catheter. Now I want you to think about that because expectation is gigantic. I was once at a medical conference where I was told that on average, patients experience at least one incident of peritonitis annually. Okay, I'm here to tell you that does not have to be true. Okay, so after PD, it was the late 90s. I was approaching more of 25 years of dialysis, and Mother Nature was catching up with me. Amyloid, I began being symptomatic for amyloidosis. The beta-2 microglobulin was collecting in my body, and I began having symptoms in my soft tissue, with my joints, with neuropathy. I knew I needed to make a change. Evaluation is crucial to managing any chronic illness for the long term. And I've always been interested is, will this therapy help me or hurt me for the long term? I decided to go back on the list. I was off the list for more than a decade. That's how well I was doing on PD. I chose to take myself off the list. I went back on the list. I used IVIG to bring my PRA count down, and I eventually did receive a third transplant, which was very good because my membrane, my peritoneal membrane, was starting to be not as efficient, shall we say, as it had been for years. I received a third transplant in the year 2000. Unfortunately, it barely worked for 3 months again. Why? I either have Alport syndrome or something unknown. As my current nephrologist tells me, Judy, you're a puzzle. And until that puzzle can be solved, it's really risky to consider a transplant. I'm probably lacking a particular protein which prevents my body from accepting healthy tissue. Okay, so the transplant worked for close to 3 months. I knew my research. I had been doing quite a bit of speaking at medical conferences and patient conferences for more than a decade while I was doing my healthcare advocacy work. During that time, I was blessed to come into contact with some top-rate physicians around the country. And so I knew that nocturnal home hemodialysis would be my next road. And that was from speaking with Dr. Periados from Canada. How many of you are familiar with his work? Show of hands. Thank you. Please get yourself knowledgeable of nocturnal home hemodialysis. Unbelievable benefits. No dialysis symptoms during the treatment or after the treatment. My labs look as if I have a kidney that's somewhat functioning. I currently have a creatinine of about 3.5, okay, and a BUN when I'm pre-dialysis of about 25-30. It's miraculous, okay? All right, next slide, please. Back one. I want to explain to you what life on the bridge. Go back one, please. That's it. When I went to be tested, no, back one. The other one. Yes. When I went to be tested for a transplant, the head immunologist said to me, Judy, you know, dialysis is simply a bridge to transplantation. And I looked at him in shock. And I said, well, you know, I've been living life on that bridge. And I'm currently working on a documentary describing my experiences on that so-called bridge. And the documentary weaves together my story, other patient stories, as well as interviews with physicians and nurses, all giving testament to the fact that you can live life on that so-called bridge if you have certain variables in place. Now, if you look here, in 1994, Medical Education Institute out of Madison, Wisconsin, put together a white paper, a very long piece entitled Bridging the Barriers. They identified several factors in response to studies that had come out in the early 90s, citing that the rate of morbidity and mortality in dialysis patients was extremely high, okay? And it was alarming because technology was moving forward, and yet the statistics were not bearing it out in how patients were actually doing. There were certain factors that were identified in what actually works in promoting not just adequate health, but optimal health. The first was encouragement. The patients need to be encouraged. In order for that to take place, there needs to be expectation on both the patient's part and the physician's and the provider's part. If the physicians or the nurses have a low expectation of what will happen, then there will be a self-fulfilling prophecy of what can happen. The expectations must remain high. When I was first diagnosed with kidney failure and knew that I would need dialysis, I said to myself, this is not going to prevent me from doing what I need to do in this lifetime. I want to be here on this planet, I want to live life, and I never thought of myself as a patient, okay? That was something I had to do in order to maintain and optimize my life, but it would not define me. Another crucial factor in what has given me my longevity is I made it my business to be educated in every area of renal care, and I internalized it and made it part of my life. In order for this to happen, you, the physicians, must take that step and see yourselves not just as providing medical care, but you, the doctors, the nurses, you are the advocates, you are the mentors, you are the teachers, you are the guides. In other words, you are the champions. Every day that you wake up and you go and take on your day, remember, you are the champions. You are who will make it happen for the people you deal with day in and day out. Evaluation. Evaluation is crucial. In today's era of dialysis being very much a corporate world, you need to remember to take that evaluation beyond the form that is on your computer. Evaluation that I'm talking about is more than simply a form where you check on the transplant list, current modality. Evaluation requires you as the care provider thinking outside the box. What does this patient need? How can I help make this patient's life better? Okay, when I evaluate my situation, and I do constantly, I am always thinking, is this working for me? Is this not working for me? How can we do this better? Next slide, please. Okay, that brings me to something that happened to me 3 years ago. Do you see my lovely little tibia and fibula? Well, this is what happened. After years of dialysis, the amyloid, the calcium absorption, everything was catching up with me. And in 2009, I was doing hydrotherapy, and I still do it today, working out in the pool. I noticed, long before the x-ray noticed, that I was having trouble moving. Okay, no one could figure it out. I was told I had weak muscle atrophy, neuropathy. Finally, I had an x-ray done, and this is what happened. I had a broken tibia and fibula. I was sent to have a boot put on it. My leg actually broke further. There was further displacement. And I began wondering what could be done because everyone was throwing up their hands. I emailed doctors who I knew around the country, and the answer came to me. I need to have a bone biopsy. And what turned out was that while my levels of calcium and phosphorus were normal in the blood system, in the vascular system, it was not being absorbed into my bones. Hence, the biopsy showed that I have very severe osteomalacia. After going and asking doctors around the country, including Chris Black, Tom Gulper, Stu Sprague, I was finally led to Isidro Saluski at UCLA. Saluski did the bone biopsy. He said to me, we're going to start giving you way more calcium and adding phosphorus to my dialysate. Okay, and he said within 4 to 6 months you will notice a change. Next slide. 2 years later, these are my bones. Without any surgical intervention, which my bones would not have been able to withstand. Slowly, with a 4.0 calcium in the dialysate instead of 2.5, and phosphate soda added into my dialysate. With that type of intervention, I slowly but surely became pain-free, once again, able to bear weight after being in a wheelchair for 1.5 years with a broken leg. I'm now able to walk again with the assistance of a walker. Next slide. It is extremely important in today's climate. Medical care is so impacted by the political climate, by accessibility of care, that standardization of care has become the norm. In a way, that's a very good thing because it eliminates substandard care and creates a more even playing field for the patients. However, protocol will only work if it goes hand in hand with individualization of care. You cannot have solely protocol to rely upon. You must be able to individualize for your patients. If I do not request, but demand excellent care and individualization of my modality and of my treatment, I would not be standing before you today. I know that. Okay? I have never gone for adequate care. Okay, that only helps patients survive. I have no interest in that. My mission is to make sure that I prevail and that I receive optimal care so that I can live my life, so that I can do my work, so that I can join my friends and my family. That is the goal for me. And that I'm sure, because you are here today, interested in learning, that that is the goal for yourselves as well, to be the champions of medical care and the champions of providing not just protocol for your patients, but individualization as well. I thank you so much for listening and for being here today. Thank you.
Many thanks indeed for that talk, and most importantly for finishing on the critical concept that protocols of care reflect the floor of the treatment, not the ceiling. It's not the aspiration. It sets the bare minimum, but adequate means providing all of the patient's needs, not nearly sufficient. Thank you very much.
Absolutely. Thank you so much.
Okay. I'm interested when you're talking about salt restriction, etc. It makes my heart run cold because we use those words restriction again. Our narrative is very sort of punishment based almost. But in your joint opinions, how much quality of life do you think is worth trading off for the quest for reduction of dry weight and the reduction of fluid removal each time? I was trained by a nephrologist who told me that nobody should be allowed to manage anybody with diabetes until they've been injected with insulin and had experienced what a hyperglycemic episode was actually like to be on the receiving end. So I understand salt was important, but Judy, first of all, how much do you think it's reasonable to expect people to tolerate for that physiological endpoint?
What I think is realistic is to consider moderation in all things. So for example, when I look at a slide that says salt-free and salt-free bread, for example, I know that to achieve moderation is more realistic than absolute restriction. That goes to some I have been told that this is a semantic discussion, but it's actually not. When we talk about patient compliance versus patient adherence, you need to partner with the patient. The patient needs to be a willing partner in this endeavor. When you approach it in terms of a punitive manner, it will never work as successfully as when you work to achieve partnership, and that requires something called education. A constant, as you said, a constant reminder to achieve a willing participant, and to go for moderation would be a far more successful approach.
Regarding internal weight gain, in my opinion, it's mostly